Now let's talk about some novel and emerging therapies. And I think there are new drugs that are coming. One of the things that's kind of being talked about a lot, even maybe for initial therapy, are two drug therapies. So Eric, what's going on there?
Yeah, so it's sort of coming back to rethinking, do we really need 3 drugs? And the potential benefits of a 2-drug regimen. And we have pretty robust data sets for first-line therapy with lopinavir, ritonavir, and 3TC. Mm-hmm. So there was a Gardell study which really sort of laid the foundation for everything that follows, showing that it really worked well. It worked as well as 2 nukes and lopinavir, ritonavir. And that was true even in people with high viral loads and low T-cell counts. I think the limitation was it was lopinavir, ritonavir. So now we're seeing data with darunavir, ritonavir, 3TC, which makes a little more sense. It's one of the preferred boosted PIs. And that data is still relatively small. There was a sort of they do all these studies very carefully, so they did a lead-in, basically to make sure things looked good before they then expanded the population. The lead-in looked good, and now they're expanding the population, so there'll be a fully powered study, but we don't have it yet.
Right.
So that's sort of one area. And the other area that's being pursued is dolutegravir with 3TC. And again, initially addressed extremely carefully, and 20 patients in the paddle study. It was actually 10, right? Made sure everything was okay, and then expanded it to 20. And it was only in people with CD4s of over 200 and viral loads of less than 100,000. Just make sure that we didn't make a big mistake, and it looked like it worked. And then the ACTG did a study where they expanded that to about 125 people and assured that 25% of the population would have viral loads of 100 to 500,000, sort of the next step. And it too looked very promising, although it is notable that there was one individual who selected for integrase resistance, which normally out of 125 we'd say, okay, 1. Right. But considering dolutegravir with 2 nukes, it's 0 still. Right. But now there's 2 large, fully powered randomized control trials that are enrolled. Right. So we'll be seeing the results from that pretty soon. And then the other 2-drug regimen that's actually in the guidelines is a boosted PI with raltegravir. And that study for the primary endpoint showed non-inferiority, but in the population of people with high viral loads of over 100,000, CD4s less than 200, it did not work as well as 2 nukes in the boosted PI. So I think that people have not rushed to that either unless there's an extremely good reason to do it in an individual with a relatively low viral load.
And I think, in the era when that study was done, there was still a lot of concern about the use of TDF or abacavir as an alternative, and so it made sense as sort of this nucleoside-sparing regimen. But it's really hard to think now, for what patient would an integrase inhibitor together with a boosted PI make sense as a first-line regimen? It works within the parameters you described, but I just don't see why
we talked about nuke sparing a lot, and now we don't talk about nuke sparing so much. Colleen, there are also now some long-acting alternatives for treatment. Mm-hmm. What do we know about those?
So I think that's kind of the next frontier in HIV therapy, is getting people that don't want to take 1 pill every day, other options. And so there's some long-acting injectable agents that are being studied. The first one is injectable cabotegravir, which is an integrase inhibitor with rilpivirine. And hopefully we would get to a point someday where people would not have to take a pill every day, and they could get injectable therapy every few months potentially, or even longer apart.
We have some preliminary data, actually in several hundred people of the injectable cabotegravir rilpivirine, either every month or every 2 months out to 96 weeks. And I guess there's two fully powered phase 3 trials, right, that we're going to hear about?
Yeah, so there's, for the monthly therapy.
Yes, for monthly, right.
And then they're just starting the every other month versus once a month therapy. So we'll eventually see, but it is all maintenance therapy.
Right, people have to be suppressed first. Right.
And that's really important.
Yeah, I think like in other therapeutic areas, there are going to be some patients for whom this is a great option, and other people are going to say, well, wait a minute, I was seeing you only once or twice a year, and now I need to come in every month or every other month to get a shot in my butt, 2 shots in my butt. Well, why would I want to do that? So it'll depend, but it'll be patient preference, I think.
Sure, and people might choose to use an injectable during a certain period of their life where maybe they're traveling or maybe they're in a setting where they don't feel like they can have pills in their possession. It might become stigmatizing in some way. So it's possible, I think. And the longer the interval, obviously, the more attractive it becomes. The longer the interval between,
in Latte 2, I thought one of the intriguing observations, but is actually very informative, was how acceptable people found it.
It's remarkable.
Yeah, which in fact, the people who were randomized to the injectable arms found it much more acceptable than the people randomized to remaining on the oral regimen, which I think is telling us that one, that for people who want it, it's very well tolerated.
Right.
And two, when people ask, so who is this for? It's going to be for the people who want it.
Right.
Very good.
Yeah.
Yeah,
That's a good point.
that makes really good sense.